Hello, this is Professor Osama Shaeer, the Professor of Andrology at the Faculty of Medicine, Cairo University, Egypt. I have been privileged with working with patients having penile curvature for over 25 years. And during the years, I have developed the current techniques to some degree of perfection. And I have also innovated new, unprecedented techniques that have made the results of correction of penile curvature much better than before. First of all, we need to define what a penile curvature is. So instead of having a straight penis, you might have a curved penis this way, or sideways, or upwards. Now, this can be congenital, meaning it's been with you since you ever recall, or is acquired, meaning that you have had a straight penis, then at some point during your lifetime, the penis started to develop a curve. The first type is the congenital curvature, while the second type is the acquired curvature. Other nomenclatures for penile curvature are penile deviation. This should be differentiated from the deviation of a straight penis, meaning that sometimes the penis is straight but is dropping downwards while still straight and can be moved in various directions. You can change the angle of the penis to the abdomen. Sometimes it's deviated upwards but still straight. Sometimes it's deviated sidewise but still straight. Now, this deviation of the erect straight penis is not classified as a medical problem because you can change the angle with ease manually, and thus you can have sexual intercourse without difficulty. This is in contrast to a truly curved penis or truly deviated penis, which can make intromission quite difficult and can cause some inconvenience and sometimes pain and erosions to ulcerations to the female partner. So, as regards congenital curvature and acquired curvature, we will discuss what causes them and how they can be treated. The cause for congenital curvature is inborn. This is an abnormality of development during the intrauterine life. By default, a gentleman should have two erection cylinders, which are straight. Each cylinder is called the corpus cavernosum. Both cylinders are called the corpora cavernosa. These cylinders fill up with blood to induce erection. In congenital curvature, suppose it is downwards, which we call ventral penile curvature, the upper surface has developed abnormally faster and longer than the lower surface, thus causing a downward curvature. In contrast, in dorsal curvature upwards, the lower surface has developed faster than the upper surface did, causing this kind of curvature, and the same applies to the lateral deviation. One point to clarify is that the definition of a curved penis applies to an erect penis. So a flaccid penis that is deviated to one side or the other is not considered a medical problem. What can be considered a medical problem is deviation or curvature in the erect state. And whether this kind of curvature is considered worthy of medical consideration or not depends on its degree and its direction. For example, if the curvature is upwards, which is dorsal curvature, sexual intercourse can be conducted without difficulty up to 30 degrees of congenital dorsal or upward penile curvature. In contrast, in a downward curvature, a degree beyond 30 degrees can be considered troublesome. Sidewise curvature, a degree beyond 15 to 20 degrees can be considered troublesome. Some patients may have more than these degrees and still have sexual intercourse with ease. Then we will be happy for them and they do not need to seek medical advice if the couple is happy with such curvature. Nevertheless, if it causes any problems sexually, which is functional problems, or cosmetically, which is aesthetic problems, we can interfere. So what causes congenital curvature? We discussed that. What causes acquired penile curvature? Now, acquired penile curvature is most commonly due to the so-called Peyronie's disease. Peyronie's disease is a state of fibrosis. And fibrosis is when the elastic penile tissue, which should expand and retract with ease, is exchanged to or changes into tough tissue that does not expand or deflate or retract with ease. And this happens at specific points. So for example, if it happens in this direction, the penis, when it expands, this point will not expand. So it will pull the penis to the same side, resulting in acquired curvature. So what causes Peyronie's disease or fibrosis? Trauma could be a cause. Fracture of the penis could be a cause. And in these cases, it is not really called Peyronie's disease. Peyronie's disease is when fibrosis has no event to justify it. And our textbooks and medical literature have not specified a specific cause for Peyronie's disease. Nevertheless, diabetes could be a predisposing factor. And one emerging theory, which I respect very much, attributes Peyronie's disease to repeated bending of the penis, which is not fully erect during sexual intercourse. So if the penis is fully erect and there is axial pressure, it should not bend. If the patient loses his erection a little bit, so he still has an erection, but it's not a full erection, and there is thrusting and axial pressure, it may bend, causing, and the repetition of this phenomenon would cause fibrosis and curvature thereby. So how do we treat this? Let's classify it again into congenital and acquired curvatures. If the curvature is congenital and beyond a certain degree that requires correction, there's no medicine for it, there's only surgery. While if it is acquired penile curvature, in its early stages, in its milder forms, there could be a medical treatment. So let's start with the medical treatment for acquired penile deviation with Peyronie's disease. The most recent development in this regard is collagenase, which is marketed under the name Xiaflex. With collagenase, you inject the fibrotic plaque, the fibrous bit or the firm bit in the penis, which is causing curvature. You inject it with collagenase enzyme repeatedly, and you perform modeling after injection between the injection sessions. And this way you are fracturing the plaque. The plaque is, or the plaque is the fibrotic firm part, which is causing curvature. You are fracturing it. You are softening and fracturing it. So by repeating the collagenase injections, you can eventually get a straight penis. This has very rare side effects, including actual fracture of this Peyronie's plaque, which results in some form of hematoma and blood seeps out of the injection site. This is quite rare. Generally speaking, it is very well tolerated and effective in the milder forms. The prior treatments preceding collagenase have been less successful in correcting acquired penile curvature, and those include injection of steroids, injection of verapamil, shockwave therapy, some medicines, oral medicines, including vitamin E, anti-estrogens, and these have not had very much success. Nevertheless, we do use them to slow down the progress of the disease. Peyronie's disease has a life cycle. It progresses during the first 1 or 2 years since it first developed, which may be way before you have first noticed it, and way before curvature has actually shown up. So starting from when it first developed, it progresses for 1 to 2 years, and then it slows down and comes to a halt, to a stop. Afterwards, you will not have any further increase of the curvature. So during this period, if we do not use collagenase, we can use the preceding treatments, the older treatments, forms of treatment, to try and slow down the progress of the disease. Then, if it is afterwards there is still a curvature and it is not responding to medical treatment, in cases of acquired penile curvature, or if this is a case of congenital curvature, then we need surgical intervention. Now, surgical intervention enjoys a very high success rate, and it is mostly a one-day surgery. The patient can leave the hospital in the same day and is normally mobile, just on the condition that the patient will keep the wound from being contaminated or being exposed to friction and tension. So it's quite a comfortable, convenient surgery. With congenital curvature, we have the following options. First of all, the shortening techniques. Second, incision and grafting. Third, penile prosthesis implantation in the most severe cases. And fourth, my own innovation, which is corporal rotation or rotation of the corporal cavernosum. With the first choice, the shortening technique, let's assume that we have a curved penis this way, downwards. So we expose the two rods by incising the skin here and pulling the skin backwards. And then we go to the point of maximum curvature in erection, and we approximate this point to that point backwards, this way. So we end up with a straight penis. We may need to do this on several points around the point of maximum curvature until the penis is fully straight. Of course, it is very apparent that this will cause curvature. Approximating this point to that point will cause shortening, excuse me, especially if the curvature is severe. Now, I have come to invent a technique which has enhanced the results of the shortening procedure for correction of penile curvature. The regular shortening techniques, they involve insertion of suture lines, which are along the length of the corpus cavernosum, the erection cylinders. And in such cases, the suture line with erection may tear through these cylinders, hence a percentage of curvature recurrence around 10%. With my invention of the AA technique, I have come to reduce this recurrence rate less than 5%. And this, the basic principle behind this is to, rather than have the suture line along the length of the corpus cavernosum, I distribute the points of entry and exit of the suture line along several points, such that when erection occurs, the tension is distributed over these points. It's as if the suture line is anchored by claws to the corpus cavernosum. So the recurrence rate is much less with the AA technique, my invention. Some cases that we see have a curvature of about 80 and 90 degrees. So if we correct these cases with shortening, the loss in length will be unpleasant. So this moves us to the alternative techniques with the higher grades of curvature, 70, 80, 90 degrees. We move on to the other techniques. The first and the oldest among them is the incision and grafting. So we work on this side, on the concave side. This is the convex side, this is the concave side. And we release the tension here by cutting and by incising this arc. And this creates gaps. The gaps will make the penis straight. After being curved, it is now straight. But there are gaps that we need to cover, so we get natural grafts or artificial grafts. We prefer natural grafts from the same patient, and we apply them to these gaps and seal them. The problem with this technique is that it bears a potential for erectile dysfunction in about 30% of cases, which is why it's been largely abandoned. The third possibility is doing this, but implanting a penile prosthesis to deal with the erectile dysfunction that may occur. The penile prosthesis is a rod or cylinder that is put inside the penis, two rods actually, and they give you erection. So I'm in favor of the shortening technique for milder cases, and I'm in favor with my own technique, which is the corporal rotation technique for severe ventral downward curvatures. This technique has been designed to eliminate the shortening that happens with the shortening techniques. What I do is, if we have two cylinders that are supposed to be straight and they are now curved this way, I rotate them. I approximate the upper surfaces and I rotate them this way, so they become straight without any loss in length. The only problem is that you will notice that there is some increase in girth in diameter here and some decrease in diameter here at the base of the penis. This is how it would look like. So this is the only downside. Otherwise, it's a beautiful technique that has been reproduced by many surgeons after me around the world, in Spain, the States, and many of them have published research papers on the results with the rotation of the corpora cavernosa. And those are available to you to review on PubMed. And I have included the links to those research papers, including mine. I have developed this technique in 2005 and have published several research papers which are internationally recognized, and this technique has been published in the textbooks that we from which we teach our students. So it's been adopted widely around the world, not with every surgeon dealing with penile curvatures, but with some of the most experienced surgeons. So to sum it up, for congenital curvatures, we have the shortening technique and the corporal rotation technique. The shortening technique will cause shortening. The rotation technique will preserve the length of the penis. I have to make a point here that the corporal rotation technique is designed to deal with cases with downward curvature, not sideways curvature. With sideways curvature, left or right, we need to go back to the shortening technique. But if it's downwards, we can apply the corporal rotation technique. Then we move on to the surgical correction of acquired curvatures, such as cases with Peyronie's disease. We can still use the shortening technique. We can still use the incision and grafting technique. And we most probably will need to use the incision grafting plus penile prosthesis implantation, because many cases with acquired penile curvatures have also some degree of erectile dysfunction. They are interrelated. So these cases will probably at some point need incision and grafting plus penile prosthesis implantation. You can learn much more about penile prosthesis implantation in my other videos. I will put also a link in the description down here. And it all depends on the degree of curvature and whether it is associated with erectile dysfunction or not. So in a case with mild, a little degree of penile curvature that is acquired, shortening will suffice beautifully. While if this is a severe case of penile curvature, acquired penile curvature, or if it's a moderate case but with erectile dysfunction that is not responding to treatment, we would advise incision and grafting plus penile prosthesis implantation. Again, incision and grafting or excision and grafting is when we remove the Peyronie's plaque, so the penis becomes straight and restores some of its length, and we apply a graft. Before we apply the graft, we implant a penile prosthesis inside the corpora cavernosa. And this penile prosthesis will give excellent erection to the patient. It will not be visible to others, and the patient can perform sexual intercourse with whichever frequency he prefers. So, for example, a gentleman with a penile implant can perform sexual intercourse several times a day if he wishes or his partner wishes to. And this has been time tested and tried for years. Nevertheless, it has the downside of affecting penile sensitivity in some cases. It is nevertheless necessary, so we have to do it on this expense or with this expense. The sensitivity is not commonly affected very much, so in most cases the gentleman will end up with a sensitive penis as usual, but in some cases there may be some affection of the sensitivity. This is because the sensory nerves of the penis, they course on top of the two erection cylinders. They course on top of them and around them. So we have to move these nerves a little bit to the side, and we remove the plaque, we implant the prosthesis, and we put the graft, and then we return these nerves again. Now the good news is I have invented the punch technique, and this has been recently published and is one of the most effective innovations in this field. And with the punch technique, I enter with an instrument inside the corpus cavernosum, so I do not have to move the nerves, absolutely do not. I enter with an instrument inside the erection cylinders, and I remove the fibrous plaques from within the cylinders. without needing to mobilize the neurovascular bundle, and I implant the penile prosthesis. A common factor between, well, let's talk complications and the downsides. The common factor between most approaches for correction of penile curvature is that there can be a recurrence rate which ranges from 5 to 10%. So the penis may become curved again. This is quite rare, 5 to 10%. And when it happens, it very rarely does it go back to its original state. So if the penis becomes straight after being like 45 degrees curved, if it recurs, it can go back to 5, 10, 20 degrees max. We have rarely seen cases that went back again to the same degree of penile curvature as before surgery. The other downside that sometimes patient can lose some of the sensitivity of the penis. So if the penis is fully sensitive, sometimes you get some areas with weakened sensation. This usually happens for about 3 to 6 months after surgery, but it usually reverts back to normal after 6 months. In some rare cases, it may persist, but it is not universal all over the penis. It is patchy loss of sensation in some patients. Furthermore, the stitches that we use to correct the curvature, if we use the permanent stitches, you can sometimes feel them under the skin when you palpate or you manually feel the penis from the inside. You can feel like some bumps under the skin. This is absolutely not a problem, but the patient has to be warned beforehand that he may sense this so that he will not be bothered with it after surgery. If we want to avoid using the permanent stitches to avoid these palpable bits under the skin, which is not a problem, but if we want to, there is a way to do that by using absorbable sutures. Absorbable sutures are suture material, which fades with time. But in order to prevent the recurrence of curvature with when they fade, we need to make small incisions on the cylinders, on the corpora cavernosa, and we suture them with the absorbable sutures. So they heal, they stick, and when the sutures fade away, they will be totally in place. The incisions will have healed, so the curvature will be corrected without the need for the stitches which have faded away. Now, if you want to visit, I have created a self-test on my website, andrologyexpert.com. With this self-test, you will be presented with several images for penile curvatures, different degrees and directions. By pressing on the picture which represents you most, you will be taken into several steps which will diagnose your case and present you with the most likely form of treatment. Of course, this is provisional diagnosis, not an accurate medical diagnosis, but it will serve as a broad guideline to you. In the end, you can send me any questions you have and maybe a picture for evaluation such that I can tell you whether this requires surgical correction or not, and this is for free, of course. Where I operate, I am based in Cairo, Egypt. I am a professor at the Faculty of Medicine, Cairo University, Egypt, and I own this hospital, which is limited to cases of andrology. So it is highly sterile because we do not admit any other cases with sepsis, such surgery that may cause infections in the operating theater. We do not have those. We sport 3 operating theaters, very highly equipped in this hospital. Our surgeries are all one-day surgeries. You can leave the hospital the same day and you can travel back home the day after immediately. But paying close attention not to expose the wound to friction, to sweating, to any sort of contamination. And you can also consult us through our online consultation system, where you can book a date and a time for the online video consultation. You can send us your investigations, your laboratory results, and your radiology results beforehand on the electronic medical files. Then we can have a video session to discuss your case. We look forward to seeing you in Egypt, and please accept my best wishes and regards.